When the treatment for hepatitis B came up, it was a true challenge, I would say. There was no treatment in 1978. In 1991, when I actually started my PhD studies around that time, it was a challenge. We only had PEG interferon and later on lamivudine. And now it's become pretty easy, but it has been easy to suppress the virus, but it's not been very easy to cure the disease, and that's what we will talk about today. So over the past 3 decades, interferons have been developed, first conventional, afterwards PEG interferon, and then 7 different nucleotides and nucleoside analogs. And we've been able to show that these nucleoside analogs have been very successful to delay the progression of cirrhosis, to reduce but not fully eliminate the risk of HCC, to improve survival, and to really prevent liver failure, I would say, to reduce the need of liver transplantation, but cure is very seldom achieved. So what are these treatments? I can go through this very quickly. There's PEG interferon, there's nucleoside analogs. PEG interferon is given for a finite duration, higher sustained off-treatment response, no resistance, but not a very pleasant drug to give, as you all know, with side effects, contraindications, and the responses are limited. Nukes are very easy. 1 pill a day keeps the hepatitis away. I always say it's a very potent antivirals that we have now. They're very easily administered orally, and they give long, but the problem is that you have to give it for a very long time. So what do we discuss today? I think it's good to just touch upon that once. There's the possibility of not treating at all. Then we have the nucleoside analogs, where there's suppression, and we really want to focus more on functional cure, which is S antigen loss or seroconversion. At least that's the true definition of that. I would say Jordan will speak more later on whether you truly need to lose S antigen to reach functional cure. And complete cure, which would be a complete elimination of cccDNA, is very difficult to reach. At least we know that functional cure happens in the natural history of the disease, and that is already a very difficult bar to achieve. So this is really where we want to go. So if you look at S antigen decline in patients treated with entecavir and tenofovir, you do not become very happy, because this is what we showed a few years ago, that if you treat patients with entecavir or tenofovir, that in the E negative population, your S levels, this is on the, let me see how this works here. I'm trying to go back. I thought there was a pointer here, but... Sorry? Oh, there it is. Oh, that's fancy. So you see in the negative population that your S levels really stay almost flat, a very, very limited decline. So these are patients who are completely virally suppressed already. And in the E positive patients, there's a bit more of a decline. And particularly if your ALT levels are higher, you tend to get a more decline of your S levels if you treat patients with antivirals. However, if you would calculate the years to become S antigen negative, it would take almost 3 to 4 decades, both for E positive as well as for E negative disease. And again, for patients with a higher ALT at start of treatment, it's a bit shorter, but still a very long time. And these figures have been confirmed in another study done from France later on. So if you look at the serological response with tenofovir, and this is the 8-year follow-up data, and this is per protocol analysis. So mind you that this is not intention to treat, it's only per protocol, so only the patients who are still in follow-up are in the denominator. The E loss gets to a level of around 50%, E antigen seroconversion a little bit lower, and S loss, as depicted here, is around 11% to 12%, around 10%, and an S seroconversion a little bit lower. So even though we treat very long with these antivirals, our ability to get S loss remains rather low. This is from the same study, but here actually we also can see the E negative population. So what I just showed was just the E positives. And if you focus really on the S antigen loss and S antigen seroconversion, you see here the 10 to 12% that I've just showed you in the bars. But here, if you look at the E antigen negative population, it's even much lower, and very seldom E negative patients become S antigen negative. I have a whole lot of patients, I would say hundreds of patients who are E antigen negative, have a very low S level sometimes, and are older, and even if you treat them longer, the S doesn't become negative. This is a study done from Korea, where they looked at nucleoside-induced S seroclearance, and also here the picture doesn't look very good, because out of the 5,409 patients that were treated, only 110 reached S antigen negativity with an annual clearance of 0.33. And once you reach that, we also know that both in PEG interferon, but also in nucleoside analog treatment, that response is very much sustained, and the likelihood of getting a relapse is very, very low in general. So what about, this is on nucleoside analogs, what about PEG interferon? Going back to the earlier studies with published in the Lancet and the New England Journal, if you look at the response to PEG interferon 6 months after treatment, E seroconversion at that time was taken as the primary endpoint, which is around 30% often reported to, but the S antigen level, the S antigen loss is very low, around 3 to 7% in the different studies, with 4% in this E negative study and 3 and 7% in the E positive studies. If you look at longer follow-up, this is from our own group, where we looked at the 64 patients who initially had a response. So we had in total around 266 patients treated, and 64 eventually responded. And the sustainability of response, if you look at E antigen negativity, so these were patients who became E antigen negative, was pretty high, 81%. This is 3 years after treatment, and 30% of the responders developed S antigen negativity. If you look in the total group, it's actually 172 patients, not 200, but if you look at the total group of 172, 11% after 3 years became S antigen negative, so a pretty low number. What about if you look even at longer follow-up? This is data that we'll present in a few days in San Francisco. There the picture looks a bit nicer actually. So this is S loss after on average 13 years of follow-up with interferon. So these are our old patients treated in Rotterdam, where very recently we went back to get their data, approached family physicians, did really everything we could to see what the long-term, the ultra long-term response of these interferon-treated patients is. And it's not bad actually. So again, this is on the left side you see, I hope it's working, no, the pointer is not really working, but anyway, on the left side you see the E antigen loss as well as the S antigen loss in long-term follow-up. I must say the E antigen loss is 71%, but some of these patients did develop E antigen negative active disease, particularly patients who have pre-core, core promoter mutations, or E positive. If you treat them with interferon, they become E antigen negative and everyone is happy, but many of them actually you bounce in from E positive active disease after a while into E antigen negative active disease, and the E antigen is lost, but the disease still moves on in a different format. So you should be careful with this number. The S antigen loss, however, is around 30%, and this is again the per protocol analysis. So mind you, this is not intention to treat. Only the patients who we could access at this point in time were tested. And if you look with a Kaplan-Meier approach, which kind of corrects for the number of patients that you lose, you still have around 30% overall S loss in patients being treated with PEG interferon. But mind you, this is after a very long follow-up period. But it shows that most probably I would say the sustainability of response with PEG interferon and S loss might be higher with PEG interferon than with the nukes. And Thomas will talk about when you stop nukes. That's a whole different story, and that's not something I will touch upon now, because there you might have the same effect as with PEG interferon. What about combination? of tenofovir and PEG interferon. This is a recently published study, and I think it's a good study because it's big, it is around the globe, it has a lot of different and important arms in there. Patients treated for 48 weeks with PEG interferon and tenofovir combined, a lead-in period of PEG interferon, and then moving on with tenofovir, so PEG interferon and tenofovir together for 16 weeks, and then just tenofovir alone and PEG interferon alone, both E positive and E negative population. And if you look at the results of this particular study after 1 year, this is S antigen decline. The S antigen decline with tenofovir even after 120 weeks is very limited, only 0.3 log. If you give PEG interferon initially, you very nicely see that here, if this starts to work, the S level goes down, but once you take away the interferon component, it really flattens in this red line. If you give PEG alone, it continues to go down. The pointer is not working very well. It's there, but it's not following my hand too well. But anyway, the blue line shows the combination of tenofovir and PEG interferon all along, where you have about 1 log decline overall. If you look at S antigen loss, which was the primary endpoint of this particular study, the group with tenofovir PEG interferon had the best response, and it was statistically significant if you compare them to the other 3 arms. But I mean, in hepatitis C world, we're talking about 95% response here. In here, only 9%. So mind you, this is really not a reason to start PEG interferon treatment in the majority of the patients, because your benefit is only 6%, and that's not worth a very toxic treatment like PEG interferon, I would say. The other problem is actually that there were some S seroreversions in this particular study. Another concept is to start with a nucleoside analog and hope for a partial immune restoration, which we know that will happen with any kind of nucleoside or nucleotide analog that you use. The viral load drives down, and then come in with PEG interferon after half a year. So kind of an add-on strategy, which we did here in the randomized controlled study. And the results are interesting because as you give entecavir monotherapy, your response rate as defined by E loss, this is not S loss, so E loss, normal serum ALT and low HBV is around 10%. And if you give the combination of these two, so add-on treatment with PEG interferon, it's a little bit higher and it's 19%. Again, only 9% difference, not a lot really, I would say. The interesting part of this particular study is that the sustainability of the response with interferon seemed to be higher than with entecavir alone. So it is not every E loss or E seroconversion is the same for each and every drug, and not every S loss might be the same for each and every drug. That's something that we have to realize very well going forward with the new and different compounds as we'll get them in our hands. So if you look at an overall picture of combination of nucleoside analog and PEG interferon treatment, is nucleoside analogs to improve interferon response in naive patients. That's not really happening in de novo. An interferon combination might happen in a few patients. Could interferon improve the nucleoside analog response in naive patients? Yes, but very limited benefit, I would say. Roughly 5 to 10%. And good interferon is to improve the response in treated patients with nucleoside analog, and add-on strategy will give you limited benefit again of only 5 to 10%. So really not worth, I would say, the treatment with interferon. I wouldn't say that interferon is dead, because it's still a very useful drug, and particularly with the new compounds, we might be able or even might need interferon in a shorter course to get to S antigen loss and functional cure. So which are the patients in nucleoside analogs and PEG interferon treatment that do well? And they kind of overlap. It's particularly the patients with genotype A, and A does do better than D in the Caucasian population, and B does do better than C in the Asian population. And whether it's actually the genotype or the wild type of the virus, because patients with genotype A tend to have more wild type virus, I would say, that we really don't know. There are other confounders as the ethnic background of the patient or the moment of infection. Those can all be taken into account here. Then patients with a lower HBV DNA tend to do better. High ALT, it seems that these patients are somewhat immune primed in one or the other way, and low S levels along the way as well. So in conclusion, ladies and gentlemen, functional cure is indicated by S loss. Seroconversion is very difficult to achieve with the current therapy, and nucleoside analog therapy is most probably indefinite in the majority of the patients. Thomas will tell us more about that. PEG interferon, whether or not in combination with nucleoside analog, has more potential, I think, still for S seroconversion, particularly long term. Genotype, HBV DNA, ALT, and S antigen levels pre-treatment might help to predict functional cure, and monitoring of S levels, I didn't really talk about that, but might help us to identify patients during treatment, so response-guided treatment, so to say. And anyway, this is kind of a nice stepping stone that we're really not there yet, and we really need new drugs to come into to the arena to get the cure that we all want. Thank you very much.